All right. We know that this one is talking about monitoring of the patient as well as some of the non-pulmonary effects that happen when we mechanically ventilate somebody. Obviously, the beginning step is having a functioning ventilator, so you got to do that self-check prior to use. There is a view from the door that you have when you walk in and you see a patient like him. You know that there's going to be trouble, that he's not doing well, just from the anxiety and the tension in his face. We don't really have so much a ventilator flow sheet because it's all done electronically now, or will be shortly. But there is points in time during the day where we go in and then we monitor the patient in the ventilator and making sure that they're doing well. Also should be some documentation whenever you make a ventilator change that you reassess what the ventilating pressure is, what the plateau pressure is, what the hemodynamic data involved is. Want to also do that before an ABG so we know what settings what ventilator settings the patient was on at the time of the analysis, and obviously whenever you have a change in patient status. Critical time is really the first 30 minutes more so because you want to see that positive pressure breath that you're utilizing. What are we doing to the blood pressure and the heart rate? Do we have good bilateral breath sounds? Is the ET tube in the proper place? Making sure that our alarms are set appropriately for that initial setup, and then looking at some other diagnostics. Normal values, you guys should have no problem at all knowing the normal values for our situations. Whenever we have a rapid heart rate, most common cause is hypoxemia, although there can be some other things like fever and anxiety can drive that. Bradycardia usually is a sign of vagal stimulation that ends up inducing a bradycardia. As we'll find the last semester, we talk about heart conduction defects, AV blocks in some fashion could be a cause of the bradycardia also. High blood pressure can be something that is basically a genetic situation, but certainly stress can lead to an increase in blood pressure also. Hypotension, low blood pressure, assuming that it's not due to hypovolemia, it could be due to a bunch of other reasons, one of which is mechanical ventilation. High respiratory rate, again, could have multiple causes. Whenever we get a rate above 30, that should be a warning sign that usually they're breathing in a rapid, shallow pattern, and that's not a good sign as far as impending failure. Slow respiratory rate would be associated with a neurological problem, and kind of get an idea on the differencing, or as far as why we're spiking a temp. We don't see hypothermia that often. Coming back from the OR, a lot of times they're chilled pretty good, but if you have a prolonged hypothermia, that's really kind of a bad sign as it relates to the central nervous system problem. So again, this is just looking at the initial assessment, measuring compliance, resistance, and auto PEEP should be thrown in there also, and just verifying that the ventilator is set up correctly. As far as chest movement, want to make sure that it's symmetrical in nature and the breath sounds are symmetrical. Most of this is pretty common sense. Fluid balance. One of the things that ends up happening when you use a positive pressure breath is you kind of trick the kidneys into thinking that there's a reduction in blood volume. So as I reduce or potentially reduce blood pressure from an increase in intrathoracic pressure, the renal system says, oh, I must be low on volume, and actually begins the process of fluid retention. When we get to the fall and talk about the function of the kidney, one of the things that is there is that juxtaglomerular apparatus, if you remember back to A and P, that senses the fall in perfusion pressure through the glomerulus and ends up actually causing ADH to be secreted, antidiuretic hormone, which basically then causes fluid retention. Obviously, the amount of fluid that we provide to the patient from the form of typically IV fluid is the biggest one, but obviously oral and GI intake have to be taken into account. But that amount should match the amount of output that they have as far as their urine output primarily, but there's also some loss in feces as well as through humidity from the lungs. If we have an excess where input exceeds output, and you end up having edema formation, and that can be problematic, especially if the edema becomes excessive, that interstitial space can be, the pulmonary interstitial space can be flooded, and you end up with pulmonary edema. Also, you end up, since electrolyte levels are measured as milliequivalents per liter, if I change the volume of fluid, I also can alter the electrolyte levels. Normal values for electrolytes, you should have those in place. And if we haven't talked about it before, I'll talk about it now, that there's a relationship that exists between the anions and the cations within the body. And primarily we're looking at an anion gap, looking at sodium, the major cation, as it relates to the two major anions, chloride and bicarbonate, and the normal value there is 6 to 12 milliequivalents per liter, if you look at the differences between them. Potassium is included in some people's way of calculating this, but that changes the normal, and I like the normal of 6 to 12 because it reminds me of buying donuts. It makes life easier.
That's what the difference should be between sodium and chloride?
Between sodium and chloride plus bicarbonate, correct. So if I take my positives and subtract off my negatives, it should be 6 to 12. And we'll find when we start talking about metabolic acidemias in the fall, one of the first things you should do if you have a metabolic acidosis is take a look at the electrolyte panel to determine if the anion gap is increased or not increased. Because that'll direct you as to what the probable cause of that metabolic problem is. And metabolic acidemias, normally we don't worry about ventilating for them, but if the defect is so profound that the minute ventilation cannot keep up with it, then we're going to run into a respiratory failure situation, or at least an insufficiency situation, because the demand is so great. Compliance and resistance, we always want to document at least the peak in static pressure whenever we go in to evaluate the patient, as well as their the level of auto-PEEP. As I mentioned prior, it's surprising how often people have auto-PEEP present. So how many times have we seen this kind of problem so far? You can see that you have a rise in peak and a rise in static going up together. That has to be a compliance problem. Actually, patients that have good compliance have more cardiovascular side effects from the positive pressure than patients with poor compliance. Seems counterintuitive, but a stiff lung doesn't transmit that positive pressure across the alveolar capillary space. So the transpulmonary pressure is less affected by in a patient with a reduced compliance. Interestingly enough. We know that static compliance, we looked at the exhale tidal volume less the total, or the plateau minus the total PEEP, and normal value on a ventilator is a little bit less than what the normal value is. Normal value would be 100 milliliters per centimeter of water. get a little bit of a reduction just by placing an endotracheal tube into the person. Airway resistance, we know how to calculate that also. As far as the peak minus the plateau, divided by the flow rate. Again, that's assuming that the flow rate is a constant flow, square wave flow pattern. And we know that they both go up together. It's a compliance problem. If the PIP goes up at a greater degree than the static does, then we have a resistance problem. You know the causes that are there. Yeah.
Going back one to measuring the static compliance, so when they're not intubated, normal static compliance is 100?
Didn't we say it was 0.1 liters per centimeter of water going way back in time?
When I was at the clinical site, she asked me what the normal compliance was because she said that his compliance was 80%, and she was like, what does that mean?
80%.
Or 80.
80, okay.
Yeah. And I was like, but it's stiff. She's like, yeah. And I was like, okay, well, what
No,
is? Like, what are you talking about? Like, what would be the normal value for that? And she was like, I don't know, you tell me. And I was like, she's like, I don't remember it. I was like,
Yeah.
so then this is for an intubated patient,
Yeah.
40 to 60.
Yeah.
So if it increases their level
Yeah,
of
80 actually is a decent number.
really?
Yeah.
Okay.
I wouldn't say that that's stiff at all. When you
No,
when you say stiff, I'm talking 30, 25.
Okay.
Okay. Now we're talking about compliance. We're not talking about plateau pressure. Make
Right,
sure
she
we're
was talking
distinction.
about-
Okay.
She was talking
Okay.
about the compliance.
Okay. There you go. Here's one example where the peak goes up, but the static does not, so that obviously there is a resistance problem. Funny, I got a text from a former grad yesterday talking about auto-triggering versus auto-cycling. And auto-cycling really is a bad terminology. When the machine is so sensitive that it continually turns itself on, that's auto-triggering. And usually we see it when there is a leak and we're using flow triggering. More often than not, flow triggering is how we ventilate somebody. And if you have a leak, the ventilator can't tell that the leak isn't the patient taking a breath, and you can end up having it continually auto-triggering. And I've had situations where, or I've heard of situations where the patient was brain dead but was triggering the ventilator. It's like, I don't think that's possible. If they're brain dead, they're brain dead. And it was just basically that there was a leak in the system and it was auto-triggering itself. That goes back a long time. When we document, it's more than just writing down or documenting numbers. It's looking to see how that interrelates with the patient. And I'm just going to skip through these because we don't really physically do a documentation per se. In fact, the way more and more the electronic medical records are set up is that you just push a button and it dumps all the data directly from the ventilator into the EMR. I don't know if yours is set up that way yet. But I mean, that's the sweetness of it, is that it'll automatically extract all the data so it's into the medical record. One key point here, looking at the delivered tidal volume, the tidal volume that we have exhaled should be within 10% of what the set volume is. So in other words, if I'm putting in 800 milliliters as my set tidal volume, I should see at least 720 milliliters coming back. There's a little bit of a give there that we're going to have. And especially with COPD patients, I don't know how they do it necessarily, but they always, if I put 800 in, I may get 700 back. Where'd the other 100 go? Well, they kind of trapped it. And periodically, they just take a bigger breath and dump. You'll see an exhale tidal volume of a liter that they kind of have saved up like squirrels with nuts in their cheek, and that they eventually spit it out. Looking at the respiratory rate, what is set is different necessarily than what they're doing. So in assist control, I can be in assist control of 14, but the patient is doing 18, meaning they're triggering 4 above what the backup rate is set at. Whenever we have a combination of spontaneous and mandatory breaths, as an SIMV. You need to account for both of them, because there's some that is basically there from a mandatory component, and then there's some that are there from the spontaneous. So let's say I go ahead and I have a patient on an SIMV, meaning that there's some mandatory breaths I have to account for as far as making up that minute volume, and there's some spontaneous breaths. I take a look at my minute volume, I take a look at my total respiratory rate, I subtract what my mandatory rate is from my total rate, that means what's left is spontaneous. I take a look at the minute ventilation that's not being made up on the part of the mandatory breaths, and what's left is the spontaneous minute volume. Divide that by my spontaneous rate, and I'll have an average spontaneous tidal volume. So here's an example of a type of question that might appear on the next quiz. You can put a star by this. How's that? I'm going to tell you what the total spontaneous or total minute ventilation is, and the spontaneous minute ventilation, the total respiratory rate, and the mandatory rate. So this is all information that would be given to you. Well, if I know that my total minute ventilation is 12.4, and 4.8 of that is being made up, actually, I tell you the spontaneous minute. I'm kind of a nice guy there. Let's go do the respiratory rate. It's probably a better example. If my total rate's 34, my mandatory rate is 12. That must mean that my spontaneous respiratory rate is 22. If I take that spontaneous minute ventilation, 4.8, divide it by my 22 breaths per minute, I find I have an average spontaneous tidal volume of 218 milliliters. And you know, I just noticed something here. Yeah, or 218 milliliters. How's that? 0.2 milliliters is awful damn small. Everybody get a gist on how you're figuring out this? It's only be in that situation where you're in an SIMV mode that you would have to determine what the average spontaneous tidal volume is. And if I told you the average spontaneous tidal volume was 218, you say, boy, that's awful small. You could use pressure support then to boost that up in the process. Although we don't normally calculate compressible volume because it is something that the ventilator determines, if you're using a ventilator that doesn't compensate for it, you'll need to determine it so you can factor it in. Hopefully there's not any leaks in the circuitry, but if there is, you need to accommodate for them also. A lot of the kids at camp, their tracheostomy tubes are not cuffed. So they ventilate them with a little bit of a bigger tidal volume, knowing that some of it's going to leak out around their tracheostomy tube. Some other monitoring that you can end up doing, looking at the end-tidal CO2, and as we'll find, that has a very good correlation with not only ventilation but also perfusion. Pulse oximetry, pulmonary artery catheters, we'll talk a lot more about at a later date, but we can monitor hemodynamic values from that. Arterial lines, we'll be able to monitor systemic blood pressure. Esophageal pressures, we don't utilize a lot, although there is some great technology out there to be able to use not only the esophageal points of trigger, but they have special nasogastric tubes that have sensors on them that we can use to have triggering happening, something called NAVA that Mary will talk about. Looking at the urine output, looking at the nutritional function, all of these are things that, again, we need to put the pieces together. Right now, the focus should be, I want to be able to know how to run that ventilator to the best of my ability. When we get towards the last few clinical rotations, the focus should be, how is this affecting the whole patient? I probably have said 1,000 times, I'll say it again. The lungs affect every other organ, and every other organ system affects the lungs. So it's not, you can't just take one thing in isolation. Once we get the patient set up, after a period of time, we'll go ahead and get a blood gas analysis. And you know that the primary way that we're going to control PaCO2 is to look at the tidal volume. To look at the respiratory rate. Once we establish a tidal volume, we typically do not change the tidal volume. We're going to use the respiratory rate as the primary mechanism to control CO2. So if somebody's hypercarbic, I'll go up on the rate to be able to, go up on the rate to be able to compensate for that. FiO2 is the primary way that will improve oxygenation. Again, that's only true once we get to about 60%. After that point in time, you have a refractory. You have to look at either increasing PEEP or lengthening inspiratory times by using a plateau. We know about respiratory system dysfunction, type 1, type 2 failure. Hypercapnia, we don't think about this a lot, but normally we think of just problems with ventilatory, either ventilatory drive or high resistance, low compliance as being the problem. But there also is the fact that you could have an increase in dead space to tidal volume ratio, like you might see in a patient who had developed a pulmonary embolism. There's a lot of wasted ventilation. There's not perfusion there to match it. And there's also increase in CO2 production simply because of patients who spike temps, have a high carbohydrate intake. Instead of a balanced diet, we're feeding them with high amounts of glucose. And in that process, they end up having a increase in CO2 production for the amount of O2 that they consume. And burns, as we'll find, are just an absolute nightmare to manage because they have not only do they have an increase in metabolic activity, they also have a huge fluid shift that goes on that can affect their oxygenation also. So when you see a high CO2, is it truly a ventilatory or a pump problem, or is it something where they're producing a lot of CO2 that they have to increase their ventilatory output to match? Oxygenation, again, not only is it something dealing with the oxygen level as far as the oxygen content, but there's also a cardiac output component there. We remember that O2 delivery formula. And again, hypoxemia in and of itself can be the primary causative agent, but oxygen at the tissue level can be impaired, which you need to take into account too. And you should know the primary causes of hypoxemia that you end up seeing. I guess you could throw low barometric pressure in there, but since the ICU typically is not hypobaric, it's not something we're going to encounter. Oh. And then pulse oximetry, we know all about some of the inaccuracies that can occur from that process. Motion, low perfusion are the two biggest problems. New technology is trying to combat that, but you still have some other issues out there. Now, one that they don't have on their sources of inaccuracy is dark pigmentation. It really does make a difference if you have somebody who's deeply darkly pigmented. Is that the right way to say that? Yeah. They have a hard time. So let's talk a little bit about effects of positive pressure on other organs. And this is out of Cairo 16 and 17 chapter. Oh, I have a video here. How did that happen? Let's see if I can get. Oh. get the gist of it. All right, normal spontaneous ventilation, just going back in time, we remember that we end up having a drop in intrapleural pressure, that as the diaphragm moves down, as the chest wall expands, that intrapleural pressure becomes more negative, and you end up having that negative pressure also transmitted across the vasculature, so the vena cava actually becomes negative, and you end up having blood being brought back into the thoracic cavity. Spontaneous ventilation actually helps increase preload. When we have positive pressure, on the other hand, everything gets reversed. You can actually get positive pressure that is high enough to cause the intrapleural pressure to become positive. At the same time, that vasculature now becomes positive, and you can actually impede the return of volume of blood back into the thorax just simply by mechanically ventilating them. We like to think that the situation on the left is what we end up having, where every alveoli is nicely, beautifully inflated, and they're all kind of inflated together. The reality is that, especially in patients with ARDS, you end up having a very nice alveoli sitting right next to a real nasty alveoli that has a very poor compliance. And when we look at a chest x-ray, we end up saying, oh my, this patient has this whiteout throughout their lungs. If you look at a CT scan, you end up finding that it's not so uniform as initially thought. Different types of trauma that can happen to the airways. Something called barrel trauma, which is basically secondary to high airway pressures that end up having. So those big deltas, we end up having more potential for barrel trauma to happen. Patients who have bullous lung disease, like COPD, are at greater risk of this, as well as somebody who is on a high level of PEEP or a high tidal volume. And patients, we don't use the terminology acute lung injury anymore. It's kind of just ARDS is ARDS, mild, moderate, or severe. The Villian Valley, how do you like those terms? Ventilator-induced lung injury or ventilator-associated lung injury. So basically, this is our fault. We're using excessive pressures, and that's what ends up leading to damage to the lungs. I've done not a lot, but I've done expert witnesses for medical malpractice trials where respiratory therapists were being sued, and one of the causes of a respiratory therapist to be involved in a lawsuit is secondary to some traumatic event, tension pneumothorax, occurring secondary to excessive pressures. Barrel trauma can have its manifestation as a pneumothorax, especially a tension pneumothorax. Can also be pneumomediastinum or pneumoperitoneum, air that actually leaks into the gut. Subcutaneous emphysema, if you haven't had a chance to observe that yet, it's one you'll never forget. Pneumopericardium, air actually being introduced into the pericardial sac, which obviously will not allow for the heart to fill properly, and it will have reduction in cardiac output. Tracheal rupture, bronchopleural fistula, those are all complications secondary to excessive pressure happening. So they're all examples of barrel trauma. And again, that's why we monitor static pressure, why we monitor auto PEEP to make sure that we're not trapping gas and having a greater risk of barrel trauma happening. Now there is something also called volume trauma, and this is basically where it's not so much the pressures are excessive, but the tidal volume itself is the culprit. So large tidal volumes cause excessive stretching of alveolar tissue, especially in that lung that has a mixture of, let me rephrase that, especially in the lung that has a non-homogeneous picture. We like to think that the lung should be this nice homogeneous compliance, that every alveoli is exactly like the next guy, But in the case in ARDS, you end up having a good alveoli next to a bad alveoli, and what ends up happening is that bad alveoli, the low compliance, all the volume then goes to the good guy. The good guy becomes overdistended, and what you end up having is that stretching of the alveolar tissue and the release of various inflammatory mediators, cytokines and whatnot, that end up actually causing the damage to the lung itself, as well as development of damage elsewhere. And this is what we end up calling biotrauma, because it ends up, those mediators go circulate around the rest of the body, and that's what leads to the multi-organ failure.
Well, don't they let the cytokines attack the type 2, which is
Types not only a type 2, but it also goes and attacks everywhere else. It's meant to be something that is a localized inflammatory response. Unfortunately, you get the pulmonary blood flow is going to go everywhere. So once it leaks into there, it kind of goes everywhere. When you see, and we'll talk about it when we talk about waveforms next, that overdistension, that beaking is called a beak. It kind of looks like a beak, I guess, above a bird. When you see that, you know that you're basically trying to put additional volume in, and basically you've overdistended the lung. And then there's something called atelectasis trauma. I hate that word. But it's not only the problem of overdistending that we end up seeing problem, it's the snapping shut that they have. So patients with ARDS, one of the problems is not only do we have to be careful not to overdistend, but we want to keep them so that you don't have to reopen that alveoli each and every breath. So they have a tendency to want to close down, and the repetitive opening and closing of the alveolar actually can cause some damage to the alveoli themselves, and just a whole nother problem. And then we talked about the release of those mediators that are present, and you end up having what is thought to be a localized healing process with the release of neutrophils and pulmonary macrophages, but unfortunately those mediators also go throughout the body, and that's the ultimate insult that ends up happening. Other pulmonary complications of ventilating, we know about this thing called ventilator-associated pneumonias, which is really unfair because it's the airway that's the culprit, not necessarily the ventilator. But if you have a patient who has an intubated, they are far more prone to develop this problem. Other airway problems, as far as just the endotracheal tube changing position, becoming plugged, accidental extubations, those are all complications we try to avoid. We know about the positive pressure, and what that also does when you overdistend is you compress the pulmonary vasculature. So positive pressure not only reduces preload by preventing blood flow from coming back, high levels of positive pressure will actually cause pulmonary vascular resistance to be increased and an inability of blood to go through the pulmonary capillary if you're overdistended it. That increase in pulmonary vascular resistance then leads to reduction in cardiac output out of the right ventricle, eventually leading to a shift in the intraventricular septum and left ventricular function being impaired. So you get it from all ends, basically, when you use excessive amounts of positive pressure. And obviously, the venous return doesn't come back. Cardiac output goes down. Hypotension develops. That hypotension then reduces the coronary perfusion pressure and increases the intracranial pressure, reduces the renal perfusion. We got a mess on our hands in the process. The blood flow to the brain, how much blood flow it gets is determined by the cerebral perfusion pressure. I won't ask you a question on this, but basically the mean arterial blood pressure less the intracranial pressure is how much blood flow is going through to the brain. When you increase ICP, one of the problems is you then reduce the amount of blood flow that is actually able to perfuse the brain, and you can end up having some neurological problems secondary to that. There is the belief that, at least in the initial phase, increasing ventilation, hyperventilating a patient with head trauma will reduce the intracranial pressure, because as you become hypocarbic, you reduce the amount of blood flow. It's one of the side effects of a low PCO2 is you reduce cerebral blood flow. Yeah, you'll drop the intracranial pressure, but the other problem is you're reducing cerebral perfusion pressure, and really what we should be doing is monitoring the brain PaO2 to make sure that we're not causing cerebral hypoxia. Sure, I can reduce the swelling, but at the same time I'm reducing blood flow to the brain. That can be a bad thing too, so there's some controversy related to it. Renal effects, as I mentioned, we end up having a reduction in blood pressure. That means I have a reduction in renal perfusion pressure. GFR, glomerular filtration rate goes down. Urine output is reduced. And then you end up having an inability to clear a lot of the waste products like urea and creatinine. And body responds by increasing ADH secretion, which reduces urine output further. And we'll talk more about that in the fall, but I just want you to recognize is that as you increase blood pressure, increase ventilating pressure, you reduce perfusion of the kidney, and ultimately urine output falls. Okay, what about the other organ systems? A lot of times just being on a mechanical ventilator in the ICU increases the incidence of stress ulcers. It impairs the ability of the liver to get adequate blood flow, which can lead to not only blood clotting problems, because a lot of the clotting factors are originated within the liver, but also you end up having impaired liver function, which means that, remember, that's the organ which is responsible for clearance or for metabolism of drugs. If it's not functioning properly, those drugs aren't being metabolized appropriately, therefore they remain in your system for a longer period of time. When you mechanically ventilate, you can't feed under normal conditions. You don't eat. So we'll have to have supplements there in some fashion, and many times they're nutritionally deprived. And we know about, specific to newborns, there's some complications that are non-pulmonary necessarily. The development of bronchopulmonary dysplasia and the development of retinopathy of prematurity. And then there's this other problem of just I can't communicate. If I can't communicate, that can lead to anxiety and fear in and of itself. Somebody's being sleep deprived, you can have all kind of anxiety. We talked about the use of, or the development of ICU psychosis, all kind of alterations that can end up happening. All right, we talked about mean airway pressure as being the area under the curve. And there's multiple things that we can change to accomplish it. Good news is mean airway pressure improves PaO2. There's just some different ways that we can reduce the mean airway pressure, shortening the inspiratory time, lengthening the expiratory time, making sure that the amount of PEEP that we're using is the appropriate level. There actually is an approach to PEEP called optimal PEEP, where we titrate the PEEP to get the best oxygenation combined with the best cardiac output. So optimizing that level. So here's an example of a reduction in flow rate. You can end up having an improvement in mean airway pressure. Here's an application of inflation hold, increasing the mean airway pressure. And we know that PEEP, as I raise that baseline, that increases mean airway pressure simply because the expiratory phase is at a higher pressure. And this is the balance that we end up doing. There's certain benefits, certain hazards. If I have a reduced mean airway pressure, that's a good thing because I'm not having as much cardiovascular side effects, but I also don't have as high of a PaO2. If I have a higher mean airway pressure, oxygenation's better, but also the risk of having some kind of damage involved. So you're always trying to balance the benefits with the hazards whenever you're having mean airway pressure involved. Nobody remembers rotary dials anymore,
I
but
still have one,
do you really?
because it doesn't go out when the power goes out.
This is definitely true. All right, let me go through Module L. Let me see if I can get the other one to work here. This is a good one. Sugar. Let me see if I can get it working later. All right. I don't think there's a ventilator manufacturer that does not have graphics anymore. In the old days, we didn't have it, but it should allow us to evaluate whether or not that patient and that ventilator are working together, and we're using it to troubleshoot. I'll spend a little bit of time talking about graphics. Mary will spend a whole lot more time in the fall going back through these, but primarily looking at two different types of graphical displays. One where it's something versus time, pressure, flow, or volume, which is what we typically see on the ventilators, but you can also look at a pressure volume and a flow volume loop. We know that there's various types of breaths, both volume-based and pressure-based, as well as spontaneous breaths. On my pressure time scaler, there's my spontaneous ventilation, where A is the inspiratory phase, B is the expiratory phase. You've seen that a couple of times now. Here's a positive pressure breath that is non-patient triggered, so it's the mandatory component. And here's one where the patient initiates that mandatory component with a spontaneous effort at point A, that little dip in pressure, be it flow triggering or pressure triggering, that starts that in breath, but it's an assisted positive pressure breath. And there's our mean airway pressure, where the distance from A to B is the inspiratory phase, from B to C is the expiratory phase. We know the various pressures here. A and E are the baselines. B is the peak inspiratory pressure. C to D is the plateau pressure. D would be the value we would go ahead and report as the plateau pressure. Technically, when you apply a plateau, that is the inspiratory phase. So the distance C there, which includes both the peak pressure and the plateau pressure, is considered inspiration. It's not until the plateau ends that the expiratory phase begins. Here's an example of a spontaneous breath in conjunction with a mandatory breath, so what would be called SIMV. Nothing new there. Looking at flow versus time, we know that there's primarily two types that we encounter, a square wave and a decelerating pattern that we'll use in volume-based ventilation. The distance A to B, again, is inspiratory phase. B to C is the expiratory phase. Volume time, really we'll just monitor the inspired and the expired volume. It's kind of a dull, boring tracing. And then look at my loops. I have a couple different things here. First of all, this is a breath which is generating some negative pressure and some positive pressure. So this would have to be a spontaneous breath. How do I know that? Because I have negative pressure and some positive pressure. So this would be the inspiratory phase on the left, the expiratory phase on the right. You can also look at a pressure volume picture. That here is mechanically delivered breath. It rises to a certain peak inspiratory pressure and a certain tidal volume being attained. That is correct. That's the distinction between the two. This is just showing again that the this curve, as it moves towards the horizontal axis, I know that I have a reduction in compliance. Opposite direction would be an improvement in compliance. And actually the distance, the width of the football, if you will, is indicative of area resistance, assuming you have a square wave curve. What do I want to say about this? Nothing. Flow volume then is what we typically see in the PF lab, but we can actually monitor it on our mechanically ventilated patient. So what are we doing with this? Well, we're looking at a bunch of different reasons why we would want to monitor the graphics. One of which is to know whether or not bronchodilators work. We're going to look at it as far as why we have alarms going off. We can detect leaks. We can detect overdistension, detect auto peep, make sure that the sensitivity settings are appropriately and adequacy of the right flow rate setting during volume control. Let's take each of these one by one. Well, we know that this value here is the peak expiratory flow rate. It's determined by the patient. Okay? The inspiratory flow rate during volume-based ventilation we determine, but the expiratory flow curve is basically variable. If I have an increase in the peak expiratory flow rate following a bronchodilator, well, that drug is working. If I don't see a change, I have no improvement in the pulmonary mechanics. Notice not only did I have an improvement in my peak flow between the before and after, but I also shortened my expiratory time, which is basically saying that the expiratory flow improved, which is what you anticipate to see with a bronchodilation. Looking at it another way, from a flow volume loop, you can see that the peak flow increased between the two scenarios. We know that when there's a change in airway pressure, can either be from a compliance or resistance problem. Typically what you end up seeing is just the patient coughing against the ventilator breath, and they'll trip the high pressure alarm in the process. Low pressure alarm, it could be that there was a disconnect or a leak in the presence, and we know that we want to assess that patient, make sure they're adequately ventilated. Here's an example of how I detect a leak and actually can quantify a leak. So here I have my tidal volume of about 1,000. Good Lord Almighty, this is the old days. And I have some degree of leak here, about a 200 milliliter leak. And I'm able to quantify in the process. Looking at a flow volume loop, my inspiratory flow curve is here. Here's my expiratory flow curve. What I'm putting in, the volume I'm putting in, 1 liter, is not the same volume that I'm seeing come back. So I know that I have some degree of leak present. Looking at a pressure volume, same idea. Where this portion of the limb is the inspiratory, this portion is the expiratory, there's a small amount of volume that's not coming back that you can quantify. Here I know that I have a leak present because I'm not delivering the full, I don't have the full volume coming back on the expiratory limb that I have on the inspiratory. This dotted line is where the flow should be, but it's not because I have some volume lost. And then because that volume is being lost, I also don't have the peak pressure that I would anticipate seeing.
Well, how did you distinguish between a leak and, say, air trapping? That if the volume's not coming back, maybe they're retaining some of that.
That's possible also. The way that I would distinct that this is not air trapping,
As you look at several different, because of the.
it's not, it's coming back to baseline, yeah. So it's not air trapping. But you're right, with air trapping, you might not see the same, you might not see the full complement of volume returning that you put in.
So you probably would look to see if it's at least coming back to baseline to
Right.
see if you had any auto peak.
Correct. And in this case, there's no auto peep, it's just a leak in the system someplace. That over-distension that can happen often happens during ARDS. We have to implement some kind of alternative strategy for using positive pressure. Here's what a normal pressure volume loop should look like. And when you have over-distension, you end up having that development of that beak. Just another picture here of it that I now have. If you think about it, I'm using additional pressure to get the small amount of volume in. That does, if I have small volume, big pressure change, that means I must have a fall in compliance, and that fall in compliance is simply because I've over-distended. There's no reason to put 1,000 milliliters into this person. 800 is sufficient. And there's just another picture of that beaking process going on. Auto peep, we know, we look at the expiratory flow curve, doesn't come back to baseline, it's there, we need to quantify it by doing a measurement. And we've seen this slide before, they're all showing various levels of, or the presence of auto peep. Looking at my trigger sensitivity, I should see a small amount of pressure change to trigger the breath on if I'm seeing excessive amounts, or if I see such situations where there's a attempt to ventilate with no trigger associated with it, that basically could be the presence of auto peep, causing that inability to sense the fact that the pressure, that the patient is generating some negative pressure and some flow, but it's not triggering the breath on. Here's an example of where it takes 5 centimeters of water to trigger the breath on. That's way too much. Something's wrong with the sensitivity setting, not being set appropriately. And just looking from a mechanical breath, here this patient is on 5 of PEEP, right? They're drawing back excessive amounts of pressure before that breath begins. So then, again, inappropriate sensitivity setting. It's just kind of breaking that out. That negative pressure that is created is the inspiratory effort prior to the breath being delivered. Now, we talked previously about when we set a patient up in volume-based ventilation, which is typically only done on the 840, the other two we use dual control to overcome this, but that peak flow setting's got to be set appropriately, and we would watch the pressure time curve to be able to say that this is where it should be, how the pressure should rise within the airway, but if I see this scooped out, that must mean that I'm having inadequate flow, and we should increase the set flow rate because the patient is being flow starved and needs additional flow. And this is just showing that as I increase the flow rate, I increase the turbulence, I increase the airway pressure. So increasing flow rate is good, that I got to match the patient's needs, but you may, as a side effect of it, have a little bit higher airway pressure. And I think we'll stop there.
Oh, jeez.